Hello everyone and welcome back to my channel. Today we are gonna give 10 tips in order to manage white cataracts as resident doctors without intraoperative and postoperative complications. Let's go and see them one by one. The first tip that we should give after the side port and the main incision is to pre-stain the anterior capsule. You use trypan blue dye to stain the capsule clearly, enhancing the visualization in the dense, opaque white cataract. Some of the surgeons are using a bubble of air after the trypan blue in order to visualize the anterior capsule better. From my experience, the bubble of air is something that you can avoid. The most important thing in this step is to let the trypan blue dye inside the anterior chamber for more than 30 seconds for a better visualization of the anterior capsule. The second step, and really important for managing white cataracts, is to maintain a well-constructed, stable anterior chamber. You should use the appropriate viscoelastic to deepen and stabilize the chamber, preventing the swallowing or collapse during the critical steps. Something that you should always be careful about is the third step, is performing a curvilinear, gentle and controlled capsulorhexis. You have to deal with two things. Either the white cataract is edematous or non-edematous, and we all know that the most terrifying complication at this step is to have an Argentinian flag. The thing that you can do if you have an edematous white cataract is to aspirate with a needle, not from the main incision, but from the side port or from another port, to aspirate the fluid between the nucleus and the anterior capsule. This is something that I'm not using a lot. What am I doing as a resident is that, first of all, with my Utrata, I'm doing a small rhexis, a really small rhexis, in order to see if there is any smoke coming outside from the anterior capsule. If there is smoke coming from the anterior capsule, this means that I'm handling an edematous cataract. I'm directly placing the IA in order to aspirate the fluid between the nucleus and the anterior capsule. After aspirating, I'm placing viscoelastic in order to have again a deep anterior chamber, and I'm continuing with my curvilinear capsulorhexis without being afraid of any Argentinian flag. The fourth step is to be able to employ phaco techniques suitable for the dense nuclei. The technique that I'm using as a resident doctor is the stop and chop technique. After doing a nice groove, I'm dividing into two segments, and then I'm aspirating one of the two segments. While I'm aspirating, I'm using the second side port with a second instrument to sub-chop the segment in order to have smaller segments in the anterior chamber to be able to aspirate them. Remember, we don't always have a good reflex in the white cataracts while we are doing the phaco emulsification. Let's go to the fifth step. As we said at the end of the fourth step, it's good to fragment safely the parts that they are coming in the anterior chamber in order to aspirate them safely. So while we're dividing the two segments and we are aspirating one of the two segments, we are using the second port with the second instrument in order to sub-chop. This has two positive effects. The first one is that you are decreasing the amount of ultrasound that you are using while you are aspirating the segments, and secondly, you can visualize better the anterior capsule and the posterior capsule because you are having smaller pieces in the anterior chamber. The sixth step is to use adequate viscoelastic devices. You always want to maintain a good anterior chamber and to protect all the structures by continuously injecting dispersive or cohesive between every step if you are not feeling safe. The seventh advice that I can give you is to manage and maintain the fluidics carefully. You should always be afraid for a posterior capsule rupture due to the sudden fluctuations in pressure. That's why you should always be careful and maintain the fluidic. Advice number 8. Avoid the excessive manipulations. You always want to maintain the cellular integrity. So try to be really gentle when you are dividing the nucleus into two segments with the method of stop and chop, while you are doing your capsulorhexis and while you are placing your IOL, because you want to maintain the integrity of your capsular bag. Advice number 9. Ensure and secure your IOL placement. If you have maintained the capsular integrity, you should place the IOL inside the bag. Otherwise, there are other techniques like sulcus, like AC lenses, like secondary IOL fixations in order to ensure and safely place your IOL after the cataract surgery. But this depends on the intraocular complications that you have. Final advice and most important advice that I can give you as a resident. A lot of doctors forget to prepare for the intraoperative complications. When you are planning a white cataract, you have bigger chances to have intraoperative complications. You should be ready for whatever it happens inside the surgery. First of all, you will need iris hooks, a capsular tension ring, the anterior chamber maintainer, you might use a loop, you might need a vanage. These are equipments that you will not have time to ask them intraoperatively. You should have them ready in order to face the challenges. In summary, I would like to conclude that the management of white cataract is not by luck, it's by techniques and by preparation.